RetinaRounds, episode number 178. Today's topic is symptomatic vitreous floaters, one of the most common and frustrating complaints faced in retina practice. In this episode, we'll discuss how to identify the ideal patient for surgical management, what makes a patient a good candidate for vitrectomy, and the intraoperative pearls that ensure a safe and effective outcome. Joining the discussion as our co-host and attending for today's case is Dr. Ehsan Rahimy. Whether you're weighing observation versus surgery or preparing for the OR, stay tuned as we break down management of symptomatic floaters. All right, Ehsan, so this first case that you're going to share with us is a patient with symptomatic vitreous floaters. Can you tell us a little bit about the patient and then the decision-making for proceeding with surgery?
Yeah, this patient had actually been monitored in clinic for over 2 years, coming in at Q6-month intervals, a little bit on the younger side. They're about 50 years old. They're phakic. Their hyaloid was down. I mean, these are all features that are almost on my no-fly list for doing this type of surgery, as we'll discuss. But the key component here, as you know, alluded to, was the time in which I've been following this patient. Many visits. I never allow them, I don't even let them entertain the idea of surgery on that initial visit. I really want to see some consistency in terms of their frustration with their vision, how the opacities are affecting their quality of life and activities of daily living, really longitudinally over time, because there's consequences of the surgery. So, after I got to know this patient over a long period of time, they eventually decided that, they wanted to do surgery, and that was something they wanted to consider.
Yeah, so that's actually there's two really interesting points there as far as the timeline, right? So there's how long the patient's been symptomatic. I mean, patients often will probably come to you. They certainly come to me who maybe they've had one or two other consultations before. They've been symptomatic for maybe 6 months, a year or longer, which is I think both of us like to wait at least that long for the symptoms to potentially improve on their own before offering surgery. But for these patients who are coming who have been symptomatic and they're looking for a solution, um, do you proceed? Because there's the other component of what you were just talking about, which is getting to know the patient, developing a relationship with them, understanding them. Um, Patients who have symptomatic floaters can sometimes there can be other factors that are contributing to their symptoms beyond just the opacities and the shadows that are created by those floaters. So can you walk us through kind of your thought process as it comes to that timeline?
Yeah, I think you kind of hit the nail on the head. The question is, can we draw a line from patient symptoms and directly attributing it to opacities in the vitreous cavity, or are there other factors? And for me personally, I don't feel like one visit is sufficient to do that. Even if they've had symptoms for many years and they've already seen other doctors, I'm not letting anybody sign up for the surgery right off the bat, especially because, as you know, this is not an urgent matter. It's not an emergent matter, and that's kind of what we're trained to usually offer vitrectomy for. So, in these cases, if somebody's had it for a long time, I'm really trying to get to the bottom of their symptoms. Fortunately, we have other objective means of, again, trying to standardize the impact of opacities on our patients, means and ways to measure contrast acuity changes and how opacities can affect that. We have some of these VFQ questionnaires that have been developed by some colleagues who are well regarded in this space of doing vitrectomy for opacities. I've seen some nice demonstrations of using Heidelberg OCT and the video function to show the infrared overlay and the visualization of the opacity. So kind of bringing that all into that encounter with the patient, I think, is key. But ultimately, what this really relies on is the patient understanding that the surgery has risks. These are very real risks that we encounter with the vitrectomy surgery. Fortunately, they're very rare. But I really make sure they understand that, there's a very real risk of endophthalmitis. There's a risk of retinal tear detachment, obvious risk of cataract progression if it's a phakic patient. These are typically, as we'll see in this video, are the types of cases I'm really trying to avoid. If I'm doing these type of cases, vitrectomy for opacities, oftentimes I prefer the patient to be symptomatic, pseudophakic, and I've already had a PVD. Those are my two big ones. So I can count on one hand in my entire career the number of times I've ended up offering and doing surgery on someone who was phakic and especially didn't have PVD and the hyaloid was down.
Yeah, yeah, and the location of the opacities matters too with respect to their lens status. Sometimes these floaters can be relatively close to the retina, and you can probably address them by doing a vitrectomy even in the phakic eye. But if they're primarily in that anterior hyaloid space, then it's very challenging to actually improve their symptoms. The other patient, speaking of lens status, the pseudophakic patients who have multifocal lenses, they're the ones who I think. Their symptoms can really be there can be a dissociation between the degree of floaters and the symptoms that the patient is perceiving. And so I may have a lower threshold, even if I'm not seeing all that much on all, multimodal imaging. If they're telling me that they're really bothered and they've got a multifocal lens, oftentimes I think that degradation in the contrast sensitivity, along with the impact of the floaters, really can have a compounding effect.
100%. I totally agree. These patients with multifocal IOLs that are bothered by opacities, it's not just floaters. They're oftentimes just bothered by the fluidic movement of symptomatic vitreous too. And in my hands, I think that the happiest patients we take care of in retina are those that have come to you with symptomatic opacities with multifocal IOLs in their eye. And another scenario I've been encountering, I think, more frequently over the years are patients who've already undergone vitrectomy in one eye for whatever reason, be it a retinal detachment, pucker, macular hole, and that underlying, retina pathology has been addressed. However, the visual acuity in that eye is not as good as the fellow eye. However, the vitreous cavity is now optically empty. And I can't tell you the number of times and again, this is not one of these things you decide off the bat, but it's just longitudinally after taking care of these patients over ensuing year, 2 years, 3 years after their initial operations, they'll telling you my better seeing eye is just really bothering me. I'm bothered by all these opacities in there. And again, it's one of those situations that they've already had their PVD and they didn't end up getting any retinal pathology. They didn't get a retinal detachment. They didn't get a macular hole or pucker. Go in and operate on those patients, and they're very, very happy.
Yep. Well, let's get into the case. So this is actually a sort of an atypical patient from what you would typically a type of patient you typically take to the operating room. This is a phakic individual without a PVD.
Yeah, yeah. I live on the younger side, 50 years old. Numerous visits. Again, I'm not necessarily encouraging surgery for these type of patients, but ultimately, and like I tell my patients, I don't live life in your shoes to know how little or much something's impacting you. And ultimately, if I can just educate you what risks and benefits of surgery are and help you make an informed decision, then we can proceed. Fellows introducing trocars in, we're in a phakic eye. You can see the opacity there, just
Yeah.
kind of huge opacity flowing back and forth and just hovering over the macula. So I think I can appreciate myself how that can be quite bothersome to someone over time.
This is 25 gauge. Do you prefer 25? Do you do 27 for these types of
I still
cases?
like 25. I'm curious to see how 27 changes things on the newer platform, the Unity that's coming out, and that should, I think, with the new sleeve, I'm being told it's going to essentially behave like the 25 we are currently used to. The older version of the 27 I just wasn't too big of a fan of.
So triamcinolone going in here to visualize the hyaloid that's still down. And so what are you telling your fellow here as far as how to engage the PV or elevate the PVD?
But I like what they're doing, Gary, kind of going in a circumferential fashion initially to the nerve. And if it's not engaging enough, again, this is a younger patient, that hyaloid's pretty stuck down. We start working our way around the arcade vessels, and you can kind of get underneath it just a little bit, start cutting, and try to propagate it up from there. Try to have them stay away from the papilomacular bundle and around the fovea in this region until they've gotten a decent lift up off of it. But again, younger patients, you gotta have to kind of stick with it and work at it a little bit. Just be patient. And then once you kind of get this lift off, I noticed too often fellows can be really zoomed in on the nerve. Actually, I want them really zoomed out and paying attention to the peripheral retina.
Hmm.
You're trying to really just do an anterior posterior look. Once you start pulling tangentially, I've noticed this is where you can encounter things like iatrogenic breaks.
Yeah, and that I really encourage our fellows not to pull once they're pulling in an anteroposterior fashion to elevate the hyaloid. Not once they see that the edge of the hyaloid, once it gets to about the level of the equator, just stop. Start
Yeah,
cutting. The fluidics will just the turbulence will
take
just
over the rest. I
propagate
totally agree.
from there. So this
Yep.
is really important here. You're doing a peripheral shave. Not everybody does, but I think this is a really important step for two reasons. One is Obviously, you want to try to decrease the risk of any late breaks, post-operative breaks that could happen from vitreous contraction, but also it allows you to really, just clean anything around any peripheral pathology that might lead to a break later on. Is that kind of your thought process of doing the peripheral shave with scleral depression?
Yeah, absolutely. I mean, one of my mentors from fellowship, Senior Garg, I always hear his voice in my head, but operating with him and training with him, we were taught like, vitreous is the enemy and we're trying to get rid of as much of it as we can. That obviously doesn't apply to like every single type of vitrectomy case, but in these type of cases, I'm really trying to do a good cleanup. And like you said, it's serving a dual purpose. I'm able to see any type of peripheral pathology, anything that has potential to be lasered, like tufts, little holes, lattice, whatever. I have very low threshold of laser any type of pathology in these type of cases.
Yeah, that's I totally agree with that. I mean, even if it wouldn't meet criteria to treat in the clinic, if I'm seeing something intraoperatively, there it's gonna get treated. You're suturing your wounds here. Do you routinely do that, or do you check to see if there's any leakage from the
Yeah,
sclerotomies before doing that?
again, it's just I think habits over time. Retina is one of these fields where I tell the fellows all the time, we're shaped of our N of ones. You just remember the one bad thing that happens in a career over training, and it just influences the things you do. So I just remember during fellowship there was like a cluster of patients. They were sutureless vitrectomy and came in post-op day one, like hypotenuse, vitreous hemorrhage. Someone got endophthalmitis, and a number of the attendings I operated with at Wills, they were pretty big on just suturing all wounds, and it just kind of carried forward for me. And honestly, I think it's good when you work with fellows, especially because when they're the ones putting in trocars, they're not always beveling the right way. Sometimes you're going straight in. They have poor wound competency coming out. And honestly, it's a good way of me assessing surgical acumen. If you can suture wounds properly, still makes me feel like a surgeon to do that. And ultimately, I think if it's my eye, that's what I want to. I found I have really good success with plain gut suture. It's far less irritative than Vicryl is. That's what we're using here.
Yeah, I was always using Vicryl when I was a fellow and early on, and you were one of the main voices that got me to switch over to plain gut. And it really, I have to agree with you. Patients are so much more comfortable. It's almost just a non-issue,
Mm-hmm.
suturing the wounds. We have had another guest surgeon on who did a vitrectomy for vitreous floaters in a phakic patient without a PVD and just did the vitrectomy, effectively just a core vitrectomy and left the hyaloid down. What do you think about that?
That makes me personally a little nervous. If it's someone who's obviously gotten accustomed to doing that and they have a lot of cases under their belt and they haven't had any issues, I think all the more power to them. Again, as I alluded to earlier, if it's when I'm operating on these types of patients, I'm essentially trying to do what I'd want for my own eye. So I probably want all that vitreous out. It brings up an interesting discussion point. I'll bounce the question back at you though, is if you're dealing with really like a stuck down hyaloid, I mean, do you just keep at it? You're going to keep trying to pull and pull and pull, or at some point do you say, all right, this is enough. I'm going to leave it alone.
Yeah, I mean, literally every step is like a risk benefit calculation, right? I mean, and at a certain point, probably it doesn't make sense to keep pulling if it's not coming up. And if you feel like you've addressed, the floaters, the symptomatic floaters, if it's probably not coming down from residual attached cortical gel, so you're probably going to be okay. But look, in younger patients, a PVD is not routinely elevated. In pediatric patients. Maybe, that extends to patients who are in their 20s. I've never operated on a patient in their that young with symptomatic floaters. Most of my patients have been just the ones that you described, the pseudophakic patients often have a multifocal lens, they've got a PVD. That to me, I feel very comfortable operating on those types of eyes. And part of the reason that I don't want to operate on these younger eyes is because I don't want to encounter issues like this where the hyaloid's tough to elevate. Maybe there's iatrogenic complications that happen with the PVD induction. Just the risk benefit profile doesn't favor intervention in my mind.
I totally agree. I'm not operating on patients that young for this complaint at all. It's like a no go. I think the situation actually comes up, which is maybe happens here and there, or when you're dealing with some of these dislocated IOL type cases. Like you had a young patient, they had trauma in their eye, they needed cataract surgery, the lens dislocates, and now you got to go back there. these are the scenarios where you're dealing with that type of a hyaloid that's really stuck down, and you may not be able to get it all up. So I don't think there's a right or wrong answer to it. I think we all have encountered those types of cases here and there. Fortunately, I've never had to like leave the hyaloid stuck down, but always wonder what would happen if we got to that point.
Yeah, I think the only time where I've been in a situation where I've had to um, do less of a vitrectomy than I wanted to was a patient who actually had asteroid. We had a case recently that we showed with asteroid. Their vitreoretinal adhesion can be particularly tight, and so I was able to get the hyaloid up to, I would say, roughly around the level of the equator, maybe a little bit posterior, and I just couldn't keep, I just wasn't coming, so I didn't want to keep pulling and potentially pull a break in the peripheral retina, so I stopped, and the patient did fine. But yeah, it's it definitely feels like there's work that's left undone when you can't do the complete vitrectomy.
Like
All
you
right.
said, it's a risk analysis, and I tell the fellows all the time too. You pull until it stops coming, and you don't pull any harder than that. I mean, some of these patients have very posteriorly inserted vitreous bases, and last thing you want to do is start creating problems.
No, that's a great discussion, Ehsan. Thanks so much, and thanks very much for sharing this case. This is great.
Awesome. Thanks for having me, Pradeep. This was fun to talk about.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.